Hello, everyone. Welcome to Achieving Telehealth's Potential, the Policy Landscape's Impact on Specialty Care. I'm Carmela Shachar, the Executive Director of the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School. We're excited to have this discussion today because telehealth has been a really invaluable tool for allowing for healthcare access during the pandemic. But as we move forward out of the state of public health emergency, a lot of the regulatory flexibilities that have allowed telehealth to bloom are being walked back. This panel is going to explore the importance of telehealth, as well as some of the notable regulatory barriers to telehealth, in particular, the issue of physician licensure. Before we get into the substance, a few housekeeping things. So the majority of this event will be reserved for a robust Q&A discussion between our panelists. So we strongly encourage you to submit any questions you have at any point during this discussion through the Zoom Q&A feature, which is found in the meeting controls at the bottom of your screen. If you would like to join the conversation or even submit questions on Twitter, we're at Petrie-Flom. We will be sharing the fully captioned event video with everybody who registered, who includes you guys, obviously, since you're here, but as well as people who registered but maybe weren't able to join today within 1 to 2 weeks. Please feel free to share that video link with your friends, family, people who you think would be interested in this event. If you have any technical issues, and I very much hope you won't, please email us at petrie-flom@law.harvard.edu, and we'll see what we can do. If you like this event and are interested in knowing more about our work, please sign up for our newsletter. It comes out twice a month, so it will not clog up your inbox, we promise. Or check out our blog, Bill of Health, to get a sense of all of the cutting-edge health policy, health law, bioethics issues that are being covered on our blog. We also have a very robust event calendar. This event is actually the first of 3 events exploring the issue of physician licensure for telehealth. The next one will be held on March 9th at noon, which will look at the federal policy landscape for interstate telehealth practices, as well as a follow-up one on March 13th at 11:30 a.m. Eastern Standard Time, looking at state initiatives in this area. In the meantime, I'm very excited to introduce our panelists for this discussion. We have Shannon McDonald, who is a physician investigator at Mass General Research Institute, associate professor of radiation oncology at Harvard Medical School, and associate radiation oncologist at Massachusetts General Hospital, as well as Mei-Hua Kwong, executive director for the Center for Connected Health Policy, and Heidi Ross, vice president, policy regulatory affairs for the National Organization for Rare Disorders. Leading us in this conversation will be our moderator, Barak Richman, Bartlett Professor of Law and Business Administration at Duke University. Barak, I'd like to hand it over to you.
Terrific, Carmel. Thank you so much. And thank you to Petrie-Flom for organizing this event and the series of events. We are at a really interesting moment. We were in an even more interesting moment during the pandemic, and coming out of the pandemic, we not only see telehealth playing a new role, but to some degree, we are at several inflection points to decide what role it should play. We are no longer being driven by the necessity of the quarantine, but we are, to a large degree, are still being driven by the necessities of managing a very complicated healthcare sector and its both possibilities and resistance to change. So without any further ado, we're going to begin with our panelists. Each one has a prepared remarks. After each of those 3 prepared remarks, we will regather in this forum for a discussion. And I again encourage everybody who's watching to submit their questions to the chat. I believe we're beginning with Shannon, is that correct?
Thank you very much for the opportunity to speak today. My passion for advocacy for telemedicine across state lines comes from the fact that I treat pediatric cancers and also sarcomas, which are rare tumors in adults. And more than 50% of my patients are from out of state. So during the pandemic, I thought it was wonderful to be able to see my patients out of state by telemedicine, to provide continuity of care for follow-up, and even to see new patients who were seeking care and seeking an opinion to determine if they needed to travel out of their own state to get care or if they could comfortably receive care at home. So it was very disappointing to have these regulations placed back in place after the pandemic, and to be in a place now where we no longer are able to provide telemedicine across state lines unless we go through great efforts to get licenses, which are limited by our hospitals and by many other conditions. So I'm going to give a perspective of the physician and also a perspective of my patients from some of the things they told me about telemedicine across state lines. So COVID-19, we will all agree, was a horrible time that we all went through. It had a very negative impact on health and took so many lives, and many of us have loved ones that were lost to this disease, patients, or just the knowledge of how many people were lost or lost function from the disease is terrible. But telemedicine, in my opinion, especially across state lines for patients that would have to travel, was a positive. We were able to provide widespread access to care through telemedicine without state restrictions. Everything was lifted and I could see patients from any state. This eased financial burdens of travel for some very ill patients. And those are out-of-pocket costs that lead to a great deal of financial toxicity for cancer patients and for other patients. And it geographically broadened access to specialty care that's available in only certain areas of the country. So rare diseases, there's not a specialist in every state that knows a lot about these diseases. For patients that had traveled for specialized treatment to another state, we were able to continue to care for these patients remotely rather than handing them back to a team that may not be as specialized in the area of treatment that they needed and didn't provide their treatment, so don't know them as well. And it also reduced disparities. And COVID certainly taught us poignantly how health inequity impacts not just those patients, but all of us. Another added benefit was decreased carbon emissions. Patients weren't getting in planes and flying or driving to come in for care. And there were actually benefits compared with in-person visits, which came as a surprise to me. So one, in the hospitals now, we are wearing masks, and I think forever will, to cut down on infection control. There's a loss of a hug with a patient or just any personal contact, and all contact has to happen through eye contact alone rather than seeing facial expressions. And through these little cameras, we were able to enter the homes of our patients, see their facial expressions. And I think for many, it reduced the anxiety of coming into a clinic and being in a cold exam room. For my pediatric patients, they could play in another room while their parents talked to us, and then the parents could bring them in at the appropriate times, rather than having to remove them from a room where they knew a more serious conversation was going on and they were not able to be part of it, and they were scared by that. For children of aging parents, they could join from different states. They could join from their workplace. They didn't have to take time off from work, find childcare. So there were some really wonderful things that came out of telemedicine. And again, surprised me for someone who didn't think it was going to be such a good experience, and would usually have said I would have preferred an in-person experience to telemedicine. And personally, I thought this would be the new normal forever. I didn't imagine a day where we'd go back to having to have our patients from out of state start to fly again and pay for hotel rooms and decide whether or not to bring their family members with them because it would be more expensive, or decide not to come at all because it was too expensive for them to travel for care, or maybe not get an opinion for a treatment that may have benefited them because it was just too much to deal with when they were dealt with the diagnosis of a rare disease or cancer. The other thing that caught us all off guard is restrictions are being enforced more aggressively than ever. And this is catching both patients and providers off guard. We are now being told that even calling back a patient after they've finished 7 weeks of treatment with you is considered practicing medicine. And that's bill or no bill, note or no note. You are practicing medicine if you call someone back and give them any medical advice. And for those of you that are not aware, the patient's location is the location of the practice of medicine, even if the visit's through the internet. So that patient must be in the state that the physician is licensed in. And I can no longer see most of my out-of-state patients. I can only see those that are within the state of Massachusetts where I practice, or in states where I've obtained a license, which are 6 additional states that my hospital allows me to, and that I had to go through a lot to get. So doctors who are caring for patients in this new normal post-COVID, who have treated a lot of out-of-state patients before the pandemic, we were used to returning phone calls, not even thinking that was practicing medicine. I would have patients send me imaging studies and I would review them and I would look at them and I would give an opinion. And now we're made aware that this is practicing medicine and we're told not to do it by our hospitals and for our own safety, because our malpractice insurance wouldn't cover it. And we are truly practicing medicine outside our state of licensure. But our patients are upset about this, and so are we. And as doctors, we're forced to choose. Do I do the right thing for my patient and give them the care that they deserve and what I think is best for them? Or do I break the rules and put my license at risk? And I think anyone who knows doctors or nurses or hospital workers, we're rule followers, and it bothers us to break the rules, and we shouldn't be forced to choose that. It's stressful and it's quite honestly just wrong. The other things that many hospitals are doing, not all, but many, require that when you start a televisit, you ask the patient where they are located. And if they are not located in a state that you are licensed in, you should abruptly end that visit. Even if it's a continuity of care visit and you know that patient, you should tell them, I'm sorry, we can't do this visit, and end the Zoom or end the telephone call. And I was speaking to a reporter about telemedicine across state lines, and I told him about a patient who routinely drove across the state line, sat in their car and did a visit with me. And he said, oh, could I talk to that patient? And I said, you could probably talk to about 50 of my patients that do that, and hundreds and thousands of others around the country that do this all the time. I spoke to a pediatrician in DC who said there's a parking lot that patients call the telemedicine parking lot, because they travel across state line, sit in that parking lot and do a televisit. And it's crazy, because then rather than being at a computer where you can see them and maybe even do a neuro exam or some type of exam, they're on a tiny little phone in their car. If they're a cancer patient and they're nauseous, they may have been feeling unwell for that car ride instead of being in the comfort of their own home. So it again just seems cool that we've gone back to the way it was before COVID, and it's even more enforced than it was at that time. And sometimes I'm told by others, oh, well, the IMLC, this Interstate Medical License Compact, makes it so easy to get more licenses. But it makes it so there is one application instead of 50 something applications, but it doesn't make it that easy. So I can tell you, I have 10 licenses. I use the IMLC for this, but each has a fee. Each needs to be renewed every 2 years. I had to take online tests for some, opiate testing that I've done before for another state, but I had to do it for this additional state. The CME requirements are different. And for 3 licenses, I had to get fingerprinted. but I was told to go back at different times in the process. So I had to go back to a police station 3 times to get 3 sets of fingerprints. And it took months to obtain some of these licenses and years for others. And after getting 10, my hospital decided that they would only cover 7, and I can't use the other 3. And I'm one of the very few physicians in the Mass General Brigham system that decided to do all of this work to get these 7 licenses because it's so hard. So I questioned, why is it this way? This seems so wrong to me, that I have to go through all of this, that I have to have a license in every state, that I can't provide continuity of care for patients that travel to see me or even call them back. And it made me think, are we really the United States of healthcare, or are we just functioning as little states competing against each other? And is this a contributing factor to why the US spends so much for healthcare and has poor health outcomes when we have specialists for rare diseases only in certain states? And do we provide healthcare for all of our citizens, or is it only those that can get on a plane and travel to see us, or that can afford these second opinion services that get around these laws by licensing multiple physicians in states, and then they're paying thousands of dollars to get a second opinion without flying? But that's not right, and that's, I don't think, what anyone intends to provide for healthcare for the citizens of our country. So what I've been told is it goes all the way back to the US Constitution, where healthcare was considered intrastate and under the jurisdiction of the state rather than interstate. So my question for all of you is there a way to change this? Are there exceptions? Could we provide follow-up care and continuity of care at minimum? Could we provide care for rare diseases? And then the IMLC, should it be the same as the NLC for nurses, where reciprocity is given for a state license and our nurses can travel to multiple states? And we would have been devastated during COVID if we didn't have the NLC. And even post-COVID are benefiting from the NLC for our nursing staff to be able to work in any hospital. And I'm going to end by just sharing a few patient stories that maybe underscore why we need some change. So I can tell you that during COVID, I saw M, who was a 54-year-old male from Rhode Island. He had a rare skull-based sarcoma. He worked full-time. He didn't show up for many of his in-person visits. And when we finally reached him, he said he was too busy to come in, cared for 2 kids. He had a full-time job, but he had an older daughter in North Carolina that we connected with and were able to do a Zoom visit with her present. And she helped to ask questions for him to make it possible for him to get care. And he went on to come to Boston for his treatment and even to get diagnosed with a prostate cancer while he was here and have that worked up. So he benefited greatly from the ability during COVID to have telemedicine visits across state line. My patient S is a long-term patient from Colorado who received treatment here years ago, came for all of her follow-up appointments, flying by herself, and then during COVID benefited from getting her imaging at home, doing Zoom visits with her husband present and her family there. And so if she got bad news, she got it with support around her. And now what she says to me is it's so sad for her to come back and fly alone for her visits. And she worries every time that she's going to be alone when she gets bad news. L is a patient of mine from Utah today who had a sarcoma. He had treatment. He wants to follow up here, but he doesn't have the money to do so without being worried that he's going to spend all this money traveling back for follow-up and not leave it for his wife and 3 daughters should he die of his cancer. And then I don't treat psych illnesses, but I had several psychiatrists reach out to me after writing a narrative. And one told me about P, a college student from Connecticut that was seeing his psychiatrist by Zoom during COVID and then had to be dropped because he wasn't allowed to see his psychiatrist remotely anymore. He couldn't get a new psychiatrist in his state of where his college was. And he ended up dropping out from college, having a psychotic break and going home. And then H is a college student who's written about in the Associated Press, as are a couple of an Associated Press article, as are a couple of these other patients who dropped out of her college at Emory to attend a virtual intense clinic for PTSD in Boston. Her family had to rent an apartment for a month. Her dad had to leave work. Her family was disconnected. She had to drop out of college where she otherwise would have been able to do the virtual clinic without dropping out. And they had to spend all of this money to never set foot in a clinic in Boston. So I thank you very much for your time, and we'll answer questions with the panel later.
Shannon, thank you so much. That was really moving. May, I believe you're second. Why don't you take over?
Thank you very much. Just give me one moment to pull up my slides here. There we go. Thank you. My name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy, and thank you for the invitation to be able to speak to you today. For those who are not familiar, the Center for Connected Health Policy is a national telehealth policy resource center. What that means is I receive federal funding to provide technical assistance on telehealth policy for essentially the nation, from everybody from the White House and Congress to state legislators to health systems, health plans, providers, and with the advent of COVID-19 more recently and more frequently to patients themselves who are confused as to what is this telehealth, how can I get services, and how extensively can I receive services. Before I get started, a couple of disclaimers. Know that any information I provide in today's talk is not to be regarded as legal advice. It is strictly for informational purposes. CCHP always recommends that you consult with legal counsel if you are interested in a formal legal opinion. And if I happen to mention a company or show a picture of a product, know that neither I nor CCHP has any type of affiliation or relationship with such a company. Now, I wanted to provide this slide, and if anybody's ever heard me speak before, you've probably seen this slide quite often because I use it quite frequently, because it gives everyone a nice overview of at least the areas, the issue areas on which the telehealth waivers that were implemented in response to COVID-19 touched. And I've divided it between federal and state policy. And the reason for that is when you look at telehealth policy, you really have to look at it through the lens of what happens on the federal level and what happens on the state level. Sometimes those policies intersect with each other in some ways, or they influence or impact those policies in some ways, either deliberately or the fact that perhaps they are replicated on the state level if something happened on the federal level, or states may sort of replicate each other or adopt policies that other states have passed as well. But if you look at the issues that they touch upon, you see a lot of commonalities, at least on the issues that they talked about, such as location of the patient. Maybe there's a geographic limit or a site limitation. The patient has to be in a certain geographic area or a certain type of quote unquote facility, a health facility. The type of modality that's being used. Are you seeing somebody through live video, or are you seeing somebody through audio only, or are you seeing somebody through an asynchronous modality, which is a capture of information you send it, sometimes like say a photograph of a skin condition that you send to a specialist. And then other issues as well, you see like there's a lot of commonalities between what happened on the federal level and what happened on the state level. However, you'll also see there are some things that are exclusively in one jurisdiction than the other. For example, on the federal level, they were controlling HIPAA, and they're also controlling how you use telehealth to prescribe a controlled substance. On the state level, and what Shannon was touching upon, and one of the issues that we're particularly interested in the session is licensure, and that is exclusively on the state level. And what Shannon was talking about, the hurdles that she runs into when dealing with patients located in multiple states, is that states control basically their licensure laws. So they dictate if you need to have a license to treat a patient within their borders and like what that encompasses. So when COVID-19 hit, this obviously created, issues with just the way the pandemic rolled out and the nature of COVID-19, that it was highly infectious. People had to isolate, so they limited contact. Telehealth was a natural sort of tool to turn to address that situation. But then you really had issues of, well, patients still needed services, and if they were receiving those services in person by crossing state lines, and now you have telehealth, they're running up against this policy barrier. So there were relaxations during COVID-19 to help facilitate that. However, 3 years into the pandemic, a lot of those, at least licensure waivers, have expired. And really, there hasn't been a whole lot of movement As far as addressing it, there has been some, and I will say the addressing of this licensure issue has been a lot more significant and rapid than what we had seen prior to the pandemic. So there's been some movement in addressing the licensure issue, but it's not been a widespread movement, and it's not been things that have encompasses multiple jurisdictions, let alone the nation. So this is our landscape of what's happening during the pandemic, when we're underneath a public health emergency, but as probably most of you know, the federal government has said the public health emergency will end May 11th. So what we'll be left with in regards to telehealth waivers and the telehealth policy landscape. On the federal level, there's been some actions, so we know what will be either permanent policy going forward after the public health emergency, or what will be at least staying around for a temporary period beyond the PHE. And a lot of that has to do more with the coverage of telehealth, which is still really important because, again, if it's not being covered, then providers aren't likely to provide those services because they won't be paid. So on the federal level, we're really basically talking about Medicare, and the major sort of waivers that were implemented with COVID-19 will be sticking around at least for a 2-year period. So these are removing like geographic limitations, allowing some providers, not all that were allowed during the public health emergency, but some providers to continue to use telehealth and still be reimbursed by Medicare, waiving some of the location restrictions, so waiving the geographic location, and also allowing the home to be an eligible originating site. Another significant piece is also allowing audio only to continue to be used to provide services. And this is an interesting point for the policy end of telehealth, in that before COVID-19, had you said audio only, is that underneath telehealth, everyone, including myself, would have said no. There were laws, there were regulations, there were policies in place that explicitly said audio only is not included underneath telehealth. The pandemic changed that. The pandemic has now brought audio only underneath the umbrella of telehealth. So now there are actually numerous policies that really do address the use of audio only and whether it is covered or not. So that's been a significant change on the policy landscape for telehealth due to what happened during the pandemic. Other things that we know is that there were some permanent policies that required a prior in-person visit for Medicare reimbursement, for the delivery of mental health services, if you waive certain restrictions such as the geographic limitation. That's been delayed for this 2-year grace period that they now have in place for these waivers. We also just last week got a bit of clarification on certain things, such as like what services will remain around as well too, because that was something that was not a congressional action, it was administrative action CMS had to do. But we also know some things are going to end with the PHE, at least with the information we have now. For example, I mentioned earlier, the prescribing controlled substances, that waiver is going to end once the public health emergency is declared over. That is something that's being looked at by the administration DA on how that can be addressed. But right now, with the information we have on what is current policy, there is a allowance to prescribe controlled substances with telehealth without having an in-person visit with the patient prior, or fitting into like a narrow exception that exists simply because the public health emergency exists. When that ends May 11th, that exception goes away. I know policymakers are very interested in like, how do we address that? We may be cutting off people who need that treatment abruptly. So far, nothing permanent or definite has come out yet, but it is being worked upon. And then some other policies related to telehealth are still a little bit uncertain on whether they would be kept around or not. On the state level, states are actually at various stages. So throughout the last 3 years of the pandemic, states have been on their own track on what they're going to keep around as far as their temporary waivers. And some states have already made decisions. They made decisions about a year or two ago saying this is going to be the permanent policy going forward after the pandemic. And they have done that. Others have rolled it back. Others have made adjustments. They cut some of the extensions. Not all of them maybe, or maybe like a lot of them. And other states have also delayed a decision to a future date. They have said that we are going to keep around these extensions until 2024 to gather more data before we make a permanent decision. So that's also been a way or path that states have like gone down. Some of the significant policy changes that we've seen on the state level, just in general, greater expansion on reimbursement and coverage in Medicaid. The second point I'll get back to in a second, allowing more providers to utilize telehealth and to be reimbursed, so expanding their eligible provider list. Before the pandemic, a lot of times you saw allied health professionals like PTs and OTs not eligible to be reimbursed for telehealth in something like a Medicaid program, including them on that list. A lot of stakeholder group convenings and studies by states, like trying to really figure out what their policies should be, or maybe trying to gather a specific type of information or research or data. And also, as I mentioned earlier, the importance and inclusion of audio-only policies, how that's also taken up and changed the policy landscape for telehealth. Now, let me circle back to the licensure issue, which is the main focus of this webinar. What we are seeing is that licensure is being addressed beyond compacts. That's still very popular. And as Shannon mentioned, that has its own issues that providers have run into in adopting them. She spoke about IMLC and also the nurse licensure compact. There are a variety of compacts out there, and it's basically by profession. So there's a psychologist compact, there's an OT-PT compact, there's a speech language pathologist and audiology compact, there's a social worker compact, there's a counseling compact, there's an EMS compact. There are a lot of compacts out there, and basically a state needs to pass legislation to join a compact in order for them to gain the benefits of it. And usually structurally the compact is you need to be a member of the compact to gain those benefits. So if state's not in that compact, then you don't really have like those benefits applied to those states. So I said that they're doing things beyond the compacts. Compacts are still very popular with states and like joining them, but they do have to join each compact individually. But other ways of addressing licensure that we're starting to see in this 2-year period that we really weren't seeing before COVID-19 are things such as, you know, more relaxation or reciprocity, or more clarity in allowing exceptions to licensure, such as, if you're only going to be doing a couple of visits a year, you don't need to get a license in our state, those types of exceptions. Or if you have a prior existing relationship with the patient and the patient is in our state temporarily, say, for example, like a student, or maybe they're traveling for vacation, the law or the policy in the state would be like, you don't need to get a license here. But those are rare and few, but we are seeing more of them. But so those exceptions are starting to gradually pop up in states. The other sort of non-licensure compact solution that we've seen in a couple of states are the creation of registries. In Florida, I believe, was the first state that did this, where instead of you get a license, you get on a registry with a state and you don't have to get a license. I don't know how difficult it is to get on the registry. Each state has their own process. From what I understand, somebody told me the Florida one is not that difficult. But you know, that might also, you know, create issues again, in that you would need to do it individually state by state to be able to do that. So it's not, again, something that's like a widespread covering multiple regions to do it. You would still have to do an individual state by state type of process, but the registry, from what I understand, may be a little bit less onerous in paperwork and maybe a little bit less expensive. So that is also like another sort of route that states are taking as well. So that's your quick overview on the policy landscape for telehealth. This is our CCHP website and a newsletter that we do weekly if you want to subscribe to it. And I just thank you, and I'll turn it back over to Brock.
May, thank you very much. There's a lot going on and you packed a lot in there. I really appreciate that. I'm sure we'll come back to it as well. Heidi, last but not least, take it away.
All right. Thank you very, very much for the opportunity to be here today. My name is Heidi Ross. I am the Vice President of Policy and Regulatory Affairs at the National Organization.
Heidi, I'm gonna just remind you, you can turn your camera on if you'd like.
Sorry about that. Hold on 2 seconds. Didn't realize I didn't have it on. Stop sharing for 2 seconds. Turn on my video. Sorry about that, everybody. Go ahead and get this. All right. Thank you so much, Brock, for the opportunity to participate in today's webinar. It's a real pleasure to be with all of you today. My name is Heidi Ross. I am the Vice President of Policy and Regulatory Affairs at the National Organization for Rare Disorders. And thank you to the Petrie-Flom Center for Health Law Policy, Biotechnology, and Bioethics at Harvard Law School for hosting today's webinar and for the invitation to share the rare disease community's experience with telehealth. For those of you that don't know, the National Organization for Rare Disorders is a patient advocacy organization dedicated to individuals with rare diseases and the organizations that serve them. NORD's a membership organization. We represent approximately 330 patient organizations, including very small nonprofits focused on the rarest of rare diseases, to larger nonprofits like the ALS Association or the Muscular Dystrophy Association. NORD offers programs of education, advocacy, policy, research, and patient services. I lead NORD's policy team, and our work focuses on ensuring that public policy at the state and federal level is meeting the complex needs of the rare disease community. As the last nearly 3 years has now shown us, telehealth has become a critical component of our healthcare system and therefore a critical component of NORD's policy work. So let's level set a little bit. What is a rare disease? A rare disease is a disease or condition that affects less than 200,000 Americans. There are around 7,000 known and different rare diseases. Some of the more common ones you've probably heard of are cystic fibrosis or muscular dystrophy. But did you know that all pediatric cancers are considered rare, the patients that Dr. McDonald sees? And it's estimated that actually 1 in 10 Americans has a rare disease. So taken together, rare diseases really aren't all that rare. This is why NORD's motto of alone we are rare, together we are strong really resonates within our community. And the reality is there are several common obstacles that the rare disease community faces, including the fact that 90% of rare diseases lack an FDA-approved treatment for that condition. Another common obstacle that the rare disease community faces is that they struggle to find healthcare providers with expertise in their condition. In the rare community, it's not unusual for there to be 1 or 2 providers in the entire country who have expertise in any specific rare condition. And a pre-COVID survey found that 40% of rare disease patients travel more than 60 miles for their routine care. And so what we don't know is who missed out on that optimal care because they weren't able to find or travel to see that right healthcare provider for their condition. This is part of why so many rare disease patients go on what we call a diagnostic odyssey. It usually takes somewhere between 5 and 7 years for a rare patient to get an accurate diagnosis. These patients end up spending a huge amount of time, energy, and money to get that accurate diagnosis. And for patients without the ability or the resources to hunt for a knowledgeable provider, they often have a hard time managing their complex health needs and can struggle to achieve those good health outcomes. And even when you do find that fantastic, knowledgeable provider, having to travel across the state or across the country to see them can be a huge and often insurmountable burden. And this is why another pre-COVID survey found that 17% of our respondents moved or considered moving to be closer to their healthcare providers. That tells you just how important that relationship is to the patient. So NORD sees telehealth as a crucial tool to advance health equity and improve health outcomes, especially for rare disease patients. So we have on this slide just a quick story that I think is really indicative of what the rare community's experience is like. Alexandra has a son with 2 rare conditions, and they have hundreds of medical appointments a year, hundreds of them. So the multitude of different appointments with different primary care physicians, specialists, mental health counselors, physical and occupational therapists is often a really significant burden for a patient and then often their entire family to take on. And then having to travel to see those providers is really oftentimes unsurmountable and an incredibly significant financial burden. So NORD believes that access to appropriate telehealth services, both in-state and out-of-state, can reduce that burden and help improve these health outcomes. So let's talk a little bit about the telehealth community, or the rare disease community's perspective around telehealth. This is a community that has a lot of complex healthcare needs. They require regular contact with their providers to manage their conditions, and COVID-19 was hugely disruptive. We had a survey that found almost 80% of patients had a canceled medical appointment in the first 5 months of the pandemic. 32% of patients reported challenges accessing their medical care. And then at the same time, 88% of patients who are offered a telehealth appointment accepted it. It's not really surprising to see that, in response to the expansion of telehealth services, 92% of patients who had a telehealth appointment said it was a positive experience, and 70% indicated they would like to have the option of telehealth appointments for future appointments. So let's talk a little bit about a good case study. So more than 2/3 of rare diseases have a genetic component to them. And so that means that advancements in genetic testing have the potential to dramatically improve the lives of rare disease patients. However, we know that access to genetic testing and access to the genetic testing workforce, geneticists and genetic counselors, can be a real challenge, and it sort of hinders the ability to reduce that diagnostic odyssey that I spoke about earlier. So a recent study came out that showed that in order to see a geneticist in person in California, which is a state that has a decent number of genetics professionals in it, patients traveled on average almost 80 miles to make that appointment, and some up to 386 miles to have an in-person visit. That's a gigantic burden. On top of that, you saw significant prior authorization delays in obtaining prescribed genetic testing. And the end result is that patients end up having a harder time getting that accurate diagnosis. Their diseases progress. They end up developing other comorbidities that, if they're lucky enough that there might be, once they get that accurate diagnosis, there might be a clinical trial operating, they are oftentimes excluded from participation because of their disease progression or because of the comorbidities that they develop, which ultimately leaves them less likely to be able to have an FDA-approved treatment for their condition. And again, just hinders their ability. That's why you look at 90% of rare diseases not having FDA-approved therapy. You have these small patient populations. And then when those small patient populations, individuals are excluded out of those clinical trials, it's hard to get an FDA approval because it's hard to show that the product is truly safe and effective for that population. So we believe increasing access to genetic testing can help, and we think that it will improve patient care. We believe it'll speed up the 5 to 7 years it takes on average for patients to get that accurate diagnosis. We believe that patients will have better health outcomes, and we believe there's healthcare savings associated with that. And telehealth can help. And I can talk later a little bit about a couple of pilots that have been going on at the state level to increase access to genetic testing. And to be clear, those are often targeted for patients that are in a hospital setting and critically ill. But a couple of interesting findings is that through Project Baby Deer in Michigan, it became the first state to make rapid whole genome sequencing a covered benefit for infants enrolled in Medicaid. And in the first 18 months of this pilot, which the results were released late last year, they found a total of 89 infants had been sequenced, and 24 of those patients had a significant change in care, resulting in an estimated 95 to 24 or 214 fewer hospital days and a net savings of almost $4,200 per patient. And then the report referenced that the telemedicine relationships between the centers participating in this whole genome sequencing initiative, both with and without on-site geneticists, were likely to help combat the difficulties that they had in terms of accessing those genetic teams. Telemedicine support for genetic counseling was really successful, and one mother commented, "We felt very supported by the genetics department from afar." Another just quick story, and this touches on the out-of-state licensure. I know that Dr. McDonald and May both went through this a little bit, but this is about optimal care for the rare disease community. This individual, Laura, she had a she identified a very good neurosurgeon in Rhode Island who was able to provide her services, and then she was able to do follow-up from home. It saved her thousands of dollars, and she felt very comfortable being able to obtain those services from an expert in the field. So we touched a lot on the out-of-state issue, and I'll just say that for the rare disease patient community, this has been a real challenge. We saw every state adjust their licensure requirements at the height of the pandemic, but those have proven to be temporary. And so a lot of our patients have really been frustrated at the extent to which those adjustments have snapped back. And even though 37 states have joined the Interstate Medical Licensure Compact, and another 21 states have some type of long-term or permanent interstate telehealth policies in place, they're not comprehensive, they're really fragmented, and they're really challenging for providers to navigate, which oftentimes means that they are, more likely to throw up their hands and say they can't do this. And there's real reasons behind that, but the patients end up really struggling to understand, why could I see that provider 2 months ago or 6 months ago or last year, and now I'm being asked to get on the plane to make that happen. And that burden is sometimes just too much for a patient who is dealing with a number of different specialists and some really complex health conditions. So NORD has done and developed some telehealth principles that are guiding our work moving forward. And at the heart of it really is that telehealth should be an option that is considered and chosen by patients and their providers. And so things like the Interstate Medical Licensure Compact and other flexibilities around licensure are really important to us, but we also want to make sure that services are covered, that they are paid and reimbursed an appropriate rate so that patients aren't being pushed to one modality or another, that it really is about how do you make sure that patient is getting optimal care, and that that decision really does lie with the patient and the provider. So a couple of things that several people have also touched on, but just one that's a little bit new that NORD's keeping a close eye on is in January, the Centers for Medicare and Medicaid Services released a state health official letter talking about interprofessional consultation, which they are now defining as enabling a peer-to-peer, physician-to-physician, or other qualified healthcare provider to assist in the consulting of a patient's care without the patient being face-to-face with the consulting practitioner. So that is something that we're excited about. It may require a state plan amendment through that Medicaid services, and there are some complications because for services across the state lines, consulting practitioners must be enrolled in a Medicaid or CHIP program in the state in which the beneficiary resides, but they only need to be licensed or credentialed in the state in which they are practicing. So that's something that we're watching closely to see if that is an option that states will take up to help improve beneficiary access to specialty care. And I know we're running short on time, so I will wrap up. Thank you again for the opportunity to be here and look forward to your questions.
Fantastic, Heidi. Thank you very, very much. So we don't have a whole lot of time, but I would, if you can actually just, there we go, perfect. There are three areas that I would love to discuss. The third one is the most important. And just to flag that, this panel, I would not say is one that is a terribly diverse one. There's a lot of agreement among us. Maybe that's because there's only one right way to look at this issue, but maybe it's not. And I want to think a little bit about what some counter arguments to what we've been exploring might be. But let's make that third. First item, it was Shannon, I think the only non-lawyer in the group who brought up a slide with the Constitution. So I don't want to blame her for this, but let's clarify if we can. And maybe you can answer this question. If we wanted telemedicine to be offered across states, we do not require an amendment or any structural change to the Constitution, correct? Tell me what are some of the measures, maybe from easiest to most difficult, that would enable cross-license telehealth, cross-state telehealth, rather?
Well, easiest in that there doesn't really need to be anything done by the federal government, is if states just agree on this. But that could be a whole other issue as far as like actually putting it in place could be kind of messy, because then you're going to have like 50, if you include DC, 51 jurisdictions trying to like do the same thing. So that could get complicated. If you're looking at a federal solution, actually CCHP wrote about this in our newsletter this week. It's probably through the Commerce Clause. And this is also an argument that's been around for a while, particularly this issue, is that with telehealth, you actually have an interstate commerce issue there, in that you're crossing state lines, there's an exchange of money because you're paying for services. And like by having a state throw up a barrier such as licensure, you're actually impeding interstate commerce there. And that's actually been brought up in a reproductive health case, the GenPro case in West Virginia, in West Virginia. It's not their main argument, but they raised that as an argument in their case in a federal court. So that's going to be interesting to see how that court rules on it. It's very narrow, it's to reproductive health. But since they raised that, that could be a springboard to like argue that with a licensure issue as well. That's like the first thing that always popped up in my mind with this licensure barrier issue that came up is, why hasn't somebody really gone for the interstate commerce argument on this if they really want to fight this? And a couple of years ago during the Obama administration, I thought the FTC may be starting to lean that way, because the FTC started to take a great interest in telehealth during the Obama administration. And then we had the Trump administration, and they kind of like lost the interest, or I don't want to say lost interest, it didn't become prominent anymore in the FTC work. And it hasn't been really picked up with the Biden administration. But I thought they may have been going that way back with the Obama administration a couple of years ago and with what the FTC was doing.
All right. So just again, to clarify for the audience, one thing we could do is every state can pass laws themselves. The federal government could pass a law on its own. It's quite possible that a judge will say this divvying up across states is unconstitutional, and maybe just a court case will change everything. The fourth possibility, what sort of administrative action, either from federal administrators or state administrators, might be able to enable cross-state telehealth?
Is that to me, or I mean,
yeah, go ahead.
Heidi, I don't know if you want to like jump in here. So there have been ways. I mean, Heidi referred to the CMS letter regarding the interprofessional interprofessional consultation letter that CMS sent to Medicaid programs. Now, Heidi, you picked up on the same thing I picked up in that letter, saying like, oh, are they saying that then, you know, you don't need to get licensed in that state? I did clarify with CMS, because I was like very shocked that they would say that. And they said, well, no, we still leave it to the state to administer. So basically what CMS did was open the door of Medicaid programs. You don't necessarily need to require a license from these providers in order for them to provide this coverage to your Medicaid and enrollees. However, a lot of Medicaid programs just within their policies do require that license for the provider, an enrolled provider. It's not like just telehealth, it's just an enrolled provider in Medicaid to be licensed by the state. So that's like two administrative acts, and CMS like clarifying that, but also the Medicaid program can just decide, yeah, we have like a narrow exception here of like, you don't need to have a license if you're just doing an interprofessional consultation.
Heidi, I know you can respond to that, but let me get you at a different question. One thing that is persistent throughout this conversation, though this problem, it's taken as a fixture that the location of the care is the location of the patient. And Heidi, you mentioned that, you know, it would only really take a law to change that. But even before could you tell me, why is that our starting point? And why would we ever start that way?
I feel like this is an artifact of a pre-digital era where the idea of telehealth was just completely not on anyone's radar. And I think that even as telehealth became more prominent in the private sector, you really saw Congress and state legislatures not necessarily fully embracing it to the extent that it could, because there was concerns about fraud, waste, and abuse. There are other very real concerns around the lack of broadband access. And as broadband has become more ubiquitous, it's more feasible to fall within standards of care and clinical guidelines to see a patient remotely. And I'm sure that Dr. McDonald can speak to that more completely. But at the end of the day, I think the COVID-19 pandemic, if there is ever any silver lining of a global pandemic, it is that it has really rapidly changed the way that both the patient community wants to engage with telehealth, and I think the way that providers are willing to engage with telehealth. And so we're just playing catch up in a way that We probably shouldn't be, as telehealth has been around now for a couple of decades in some manner or another, but we're just really behind.
And maybe that's the best way to get into this last issue. Shannon, one way to characterize your talk is patients love it, providers love it. What's not to like? And not only are we seeing these emergencies, temporary measures remaining temporary, not only are we going back to a world of pre-pandemic, but in many ways, there's even a more significant retrenchment. What could possibly explain that?
So I think just bringing up, just highlighting what the rules were before, where we weren't, considering a telephone call back to a patient practicing.
Could I challenge you a little more? Just because the rules are there doesn't mean that people are going to enforce them. There probably is a reason that these rules have gotten more attention, but I think there's probably a different reason for why they're being enforced.
So I think the hospital lawyers are looking at them and giving us lectures on what we can and cannot do. And telephone visits were considered telehealth visits. They were billed for, notes were written. And now when we receive lectures, someone who wasn't really thinking about how it was before is saying that is practicing medicine. And also telling us bill or no bill, note or no note, you are giving medical advice. And hey, you never should have been doing that. But we did not even think of it as practicing medicine before we all did so much telemedicine. We just thought of it as, hey, a patient calls me, I call them back. And I'm not saying everyone stops doing that. We're torn between doing what's best for our patient and what our legal staff is telling us is safest to do. And that's not fair. It's not a fair position to put it's not a fair position to put a physician in. And I do agree with all of you saying that I think it's where this comes from is it's just so dated. It's from a time before the internet, maybe, where these rules started, and they've just evolved as being under state guidance and state rules. But if they really did start in the 18th century, you'd have had to take a horse to get to another state, and you probably would have had a disease that you would have died from by the time you got there. So it's just, there was no internet, there were no cars, there were no planes, and things have changed. And COVID just opened up telemedicine in a way that was so rapid, and it's now so hard to go back. And patients are really—
And it probably wasn't the end of the 18th century, probably the end of the 19th century, the progressive era, but I don't think medicine was much better in the end of the 19th century than the 18th century, but never mind that. May, why are the lawyers in Shannon's hospital representing that view and representing it so vociferously? Because my sense is that if you were to poll most health lawyers, there would be a much greater variation in how people view the law and in interpreting what kind of actual flexibility there is. Why is Shannon only getting one side of the story?
For the most part, lawyers are risk averse. So they're always going to go the conservative route to protect their client. That's actually what you want a good lawyer to do. It's like I
disagree with that, but never mind.
They want to avoid the trouble before it happens. So they are going to go the most conservative route. I think you might be trying to get this, but this may just be my cynical old mind thinking here. It's like, why do these things still exist? And one of them is they're a revenue generator. So that's one reason, not the only reason. There are actually, I think, some legitimate arguments that I have heard people bring up, such as there's concern in how you regulate them, these interstate telehealth providers. If they do something and the patient is in your jurisdiction, how do you go after that provider then who's located in another state? Like, where's the jurisdiction? What are your ways of basically regulating that? So that's, I think, a legitimate concern that people have brought up regarding this. But, there are also other sort of, I think, a little bit more selfish concerns for some folks, not everyone, regarding trying to bring down these telehealth barriers, which is it's a revenue generator. There's concern maybe of competition coming into your community from these outside telehealth providers, and your community providers might be a little bit concerned about that as well. So it's not, I think it's not as cut and dry sometimes on it. And there's these different factors in play here as well. Some of them really about patient safety and definitely about that and quality of care. But other also like my more cynical side of like, you're worried about outside competition too, probably.
So we have 30 seconds left. Heidi, I'm going to give you the last 30 seconds. If in fact May is correct, if in fact that a lot of the reason we see this retrenchment is because it is more profitable to continue with bricks and mortar medicine, how might your organization and others like it make it more profitable to pursue virtual models?
Yeah, I mean, it's a great question, Barack. And I think that part of it is really about making sure that the reimbursement rates are there to support telehealth. I think there also has to be an acknowledgement that telehealth is not a silver bullet for the practice of all types of medical care. It has an appropriate setting. So we need to incentivize telehealth services where appropriate, recognizing they reduce those patient barriers. But we also need to make sure that we're adequately reimbursing our brick and mortar facilities so that when patients do have those needs to be seen in person, they can obtain those appointments and be seen. And it is a place that leaves patients in a really vulnerable spot as they're navigating this. Telehealth is new to a lot of us. It's new to a lot of rare disease patients, and they're feeling that whiplash all the time. And oftentimes, as Alexandra in my example said, hundreds of times a year as they are dealing with different medical appointments.
Well, terrific. Well, let's end it there. Thank you very much, all three of you. I think at the very least, we recognize that this is something that is somewhat of a moving object and a changing story. There's a lot of activity. And I think as Heidi and Shannon indicated, there's also a lot of angst with the current situation, and there's a real hope that we can improve upon it. Well, thank you, all three of you. Thank you to Carmel for organizing this webinar, and thank you for the Petrie-Flom, and thank you for our attendees as well. And we will have 2 more additional webinars on this topic. We look forward to seeing you all there.
Thank you all very much.